did try and design these so one would follow the other. So hopefully it doesn't feel like a 40-minute lecture, and more like 2 easy-to-digest 20-minute lectures. Yes. So now we're going to take some of that basic science, some of that theory, some of those studies that we just heard about, and start to apply that to how we would teach our own trainees, how would we teach our medical students, and even how we would teach our colleagues and our patients. Same disclosure. So I want to start out with one quote from Marshall McLuhan. And he was a writer and a researcher who years ago, mainly in the late 60s and 70s, wrote extensively about a new technology that was changing our lives, changing the way we interact with each other, changing the way we think, changing the way we think about our world. And that new technology, which at the time was very scary and regarded as something that may not be good for society, was television. Well, television certainly lasted, and his warnings about the effects of television on society may have been a bit exaggerated, but I think he's right when he does say that we are shaped by our technology and what it enables us to do, see, experience, and more than anything, communicate. And it's these communication technologies that are really changing the way we interact with each other, and especially education. So I got this little animation that shows you as the sun crosses the earth, this is the activity on the internet at various locations in the world. And you can see that South America is asleep right here, and now it's waking up, becoming quite active, and then the activity goes down. But I only bring this up as an example of how pervasive and widespread internet technology is. And if you're not yet convinced, this is a graph showing you on a logarithmic scale how many millions and now billions of internet hosts there are on the earth. So now there's an internet server for every 7 people that exist on this planet. So how has that changed the way we interact with our students and how we teach? How does that support developing expertise like we just talked about? And how can we use internet and other new technologies to advance our teaching? And how, as gastroenterology educators, can we use that and combine it with traditional methods to achieve expertise in our trainees? Well, I did find one quote that I like a lot. It was actually in Spanish from a musician. Anybody here hear of Frank Zappa? Okay, we have a few. Frank was a what we would call a quite avant-garde experimental musician who was always trying new things. But I like his quote. In English, it's, "Without deviation from the normal, progress is not possible." And what I think he's trying to tell us here is that you have to be ready for change, and you have to accept change. Unless you want to stay where you are, progress requires change. I'm bringing this slide up again just to remind you how much the relationship between knowledge and educators and the students has changed. And they have all these different resources in which to interact with, and they do interact with. These students are different. They prefer to work in groups. They're more collaborative than we were. They are more confident and connected and open to change. And they are constantly connected to each other and, importantly, connected to the entire world. Our students no longer think of their education as something that just happens within the 4 walls of the University of Pittsburgh. In fact, they very much see their education as something that is part of something more global, as something happening around the world. I like this picture because it does embody some of what's changed in the way students prefer to learn. This was a photograph from a classroom at Stanford where the students are engaging in all types of activities. You can see there is a lecture type materials, maybe PowerPoint slides here on the wall, but nobody's really looking at it. There is a teacher in here, but she's not just looking at the class. She's wandering around and interacting with students. You'll notice every desk has a laptop on it, probably more than one. And then over here on the side is some sort of electrical device. I think it's a simulator of some sort in a class teaching electrical engineering. And one more very important component of teaching that's in here is that they're doing it together, collaboratively. So they're learning around a simulation, using references off the internet, using some references from the teacher, maybe getting some help, but doing all these things simultaneously. That's a big change from the way that a lot of us did and sat in rooms like this and listened to somebody lecture on and on and on for hours. So we've got different methods of teaching that we can use to draw from. There is still a role for instructor-led teaching. I think for dispensing knowledge and the basics of medicine, it still has a good role. But there are a lot of self-directed learning is now on the computer, mentored learning where you have an expert working side by side with the student, and then group learning. These all have their roles and their opportunities. And I've translated 3 of these into simulation-based methods of education. Here, the self-directed can be using virtual patients, maybe a colonoscopy simulator, mentored work at the bedside, in this case, learning how to intubate a patient, and then group work dealing with emergencies and trauma. There's a number of resources out there. Your students, I'm sure, have found things like the DAVE Project, which has a vast collection of endoscopic procedures that are well narrated and well edited. It has a collection of lectures from some of the Harvard schools and Boston schools. Sorry. I hit the wrong button. Even the expert technologist hits the wrong button once in a while. All right, so in gastroenterology specifically, we have an opportunity to use virtual patients. These are online interactive simulations that simulate disease from patients from all over the world in rare and important conditions in addition to the ones that your students are likely to interact with at your own hospital. There are part task trainers, and endoscopy simulators that aid in psychomotor development, and then there are the high-fidelity mannequin simulators that are better for teaching team dynamics and managing things like codes in the emergency room. The virtual patients, this is one example. This one is of a patient that comes with a history of inflammatory bowel disease and knows that she needs some screening, wants to get a CT colonography instead of a colonoscopy, and the student has to work through the decision-making, whether to do a colonoscopy, whether to wait a year, whether to wait 5 years, or maybe do, as she's asking, do a CT colonoscopy right away. Different things can happen to this patient based on the student's decision-making. In this case, she had some surgery, and now you have to decide what the screening and surveillance will be after surgery. And this is a little look behind the scenes as to what's happening in that virtual patient, where there's many different directions this case can take, and it's giving the trainee the opportunity to make mistakes, but in a safe environment, to see what happens if they make the correct mistakes and the incorrect mistake, and to get that feedback online. And if that sounds familiar, that's very much what Erickson is telling us that is the method that we can best develop expertise. And the nice thing that students like about it is they can do these on the bus, at home, at night, and engage in some of these 3D simulations where they're working in groups instead of just independently. And even old guys like myself can practice on these colonoscopy simulators. I'm curious, any of your programs using these colonoscopy and endoscopy simulators? 1, 2. Yeah, they're not as in widespread use as the manufacturers would like, but I can tell you from using them many times, and we have our trainees go to them, they're very good for that initial practice on just using the controls, how the buttons work, the basic movements of colonoscopy. And these are nice because they give you also feedback. They can time how long it took you to get to the cecum. It determines how much air you insufflated into the colon. And it gives the students a lot of discrete, objective feedback, and much of what we don't do when they're training. Another relatively new approach to training physicians is using not just standardized patients. That's been around for a while. That's where actors act out a disease and interact with a clinician and he has to figure out what the patient has as the patient acts out and describes symptoms and maybe even has a particular disease. We have a number of patients who have volunteered who have liver disease, who have Crohn's disease, who have different skin lesions that that volunteer to work with our trainees as actors and standardized patients. This is a new approach to it where it happens electronically, where the doctor and the trainee can talk to a patient who actually is located in another location. She can talk to him over an internet connection, and she keeps track of whether he asks the right questions, and he gets a report and some feedback regarding how good a job he did interviewing this patient, and even how good a job he did counseling her on what disease she has, what the treatment should be, and what to expect. And a lot of the diseases that we treat maybe don't have a very good prognosis, and maybe the techniques and the skills in being able to talk to a patient about bad news is more important than just our ability to diagnose somebody with a fatal condition. We're seeing now some combination of putting these things together. So the VA health system in Dayton, Ohio, has a system where they start out with a virtual patient and work through online a number of the history, some physical exam findings, a number of questions about what diagnostic tests to order, but then have to go to a mannequin and do a physical exam. In this case, she's doing a breast exam, and then go to more of a mentored experience where you have an expert helping her learn how to do a pelvic exam. So by combining the use of online technologies, the use of simulators that students can do on their own, and that mentored experience that you can do at the bedside, you can maximize the benefit of these different technologies. The surgeons also have come up with a method to develop expertise. They call it their mastery model, where most of the time is spent online learning the basic knowledge. Then the surgery residents go on to learn more sophisticated concepts like guidelines and evidence-based clinical information. And then once they've mastered that, go on to practice on some virtual patients online, and then eventually get into the simulation center where they're practicing with simulators, laparoscopic simulators and other simulators, and then get to the operating room. And what's unique and important about this is that this isn't just spend your own time. This is a discrete, structured activity that requires passing the basic knowledge test before you can go on to learn the guidelines, and requires you to be competent and have mastered the guidelines before you're able to start practicing on virtual patients. So each one of these steps requires proof that you've completed, and not just completed the exercise, but also can demonstrate that you're competent and have mastered that concept before you go on to the next one. So again, it's more about coaching and less about teaching using lectures and more traditional methods, because we have the tools now to do things in a more sophisticated way. Not that lectures are gone. There's still a few of these events for our fellows, but there's more of this now where we're teaching every step of the way and designing our educational experiences so that they match the students' needs. So setting goals, and so things like how long, what score you should have on a colonoscopy simulator, and how fast you should be at getting to the cecum before you ever even come to the GI lab and start practicing on real people. And then once you are there, we should be timing how long it takes our trainees to get to the cecum, and tracking and showing them progress. We also have the responsibility to create motivation, create enthusiasm to be a gastroenterologist, live as a good example of continuous improvement, and be showing your trainees that you yourself are always improving. Every time I have a trainee in the room, we time how long I spend going from the cecum to the anus, and making sure that I don't go under that 6.5 minute recommended amount of time. And it's important that they see that. And then giving feedback. This is something that we're used to doing perhaps at the bedside, giving immediate feedback, but this can also be done online through virtual patients and other simulation activities. And then importantly, and built on kind of Erickson's work, showing that you can't just teach somebody how to do something. That person has to practice it. And the more practice, the better gastroenterologists your trainees are going to be. But that practice isn't just practicing in isolation. It's practicing with you there, giving them feedback every step of the way, creating challenges that progressively get harder and harder, and that include both time in a controlled situation like a simulation lab, and then especially time at the bedside with real patients. So in case you're wondering whether or not simulation and technology can really have an effect on students, I want to leave you with one image. And this is a student who just found out that she killed her virtual patient. And so the simulations can be as impactful, and I tell you, I'm happy she did it there and not in my endoscopy lab. So thank you very much.